Hello friends, so this is the third case of our series of uncut video demonstration of full endoscopic spine surgery. So here today I am going to demonstrate again a very simple case for the beginner. So it will be a L5S1 paracentral disc prolapse on the left side. So in this case we are going to do interlaminar endoscopy on the left side. So this case is ideal because this is L5S1 disc paracentral disc prolapse. At the same time, in this patient the interlaminar window is very wide, so this is actually an ideal case for the beginner to start with, because in such cases you do not have to do bony decompression, so you can just do the phlebotomy and you can complete your entire surgery within just a small phlebotomy incision. So let's begin with the MRI. So here this is a young male patient. He's an army personnel. So he was having severe left-sided leg pain with a bit of list on the left side. So the pain was there since last 4 to 5 months. So this was the first MRI, 4-month-old, where you can see there is a disc prolapse on the left side, which is paracentral. But recently his pain is aggravated, so he is not able to do. So you can you know that as he's an army personnel, he has to do PT and everything. So recently he has realized that he is not able to do his routine work, and the pain has aggravated more compared to the previous findings. So this is the second MRI, 4 months apart. You can see here the disc prolapse on the left side has increased. So there is a big fragment now, which is contained fragment, sort of contained fragment here. So now our plan in this case is to do left-sided interlaminar endoscopic discectomy, monoportal. So we are not going to do bony decompression in this patient because of the wider interlaminar window, which I am going to show you in X-ray. So this is the X-ray of the same patient. You can see here there is no instability. In AP X-ray you can see the L5S1 interlaminar window is very wide in both the directions, like it is wider horizontally, at the same time it is wider vertically also. So in such cases you do not have to do any bony decompression. You can directly go inside by making a small phlegm window. Next step here is incision. So how to take the incision, how to identify the accurate landmark for the incision. So as far as the interlaminar endoscopy is concerned, the spinolaminar junction is the ideal landmark for the incision. So if you consider all the cases, like you can use this incision in stenosis cases, you can use this incision when the interlaminar window is wide or narrow. So this is all season incision which will be at the spinolaminar junction. But in such cases, particularly at L5S1 where the interlaminar window is very wide, you can avoid spinolaminar junction incision. See, the thing with spinolaminar junction incision is that you have to do bony decompression in all the cases, because you are landing onto the superior lamina, so you have to do bony decompression to create this space. But in such cases where the interlaminar window is very wide, you can avoid bony decompression, as we already discussed. So here you can see the interlaminar window is very wide, so you can take an entry, you can take an incision in the middle of the interlaminar window in a vertical dimensions as close to midline as possible. So reason why? So if you take incision in the center of the interlaminar window closer to the midline, you all know that we usually start our phlegm resection from medial to lateral. Why medial to lateral? Because laterally the neurological structure, that is the traversing nerve, is very closer to the ligamentum phlegm. So you do not want to damage that ligamentum phlegm by starting from the lateral side. So you usually take incision, you usually start ligamentum phlegm from the midline. So you know that near the midline, the dura is far away from the ligamentum phlegm. The epidural fat lies in between. So if you take first bite at the towards the midline, there is very little chance that you will going to damage the dura. So here I always take incision in AP view. Few people they prefer to take incision in lateral view as well, but I always prefer to take incision in the AP view. Now after the incision, the next step is placement of the dilator. So once you take the skin incision, you have to take the deep fascia incision as well. So try to take that deep fascia incision in a one go. Do not try to make multiple incisions. Sometimes if you take multiple incisions, your dilator may go to some different incision, and again during surgery there is very high chances that the water may come out of the from the different incision, and it may cause subcutaneous edema as well. So try to take deep fascia cut in one incision. So once you take the deep fascia cut, now it's time to put the dilator inside. So whatever, if you are using the stenoscope or using the discoscope, take the dilator and insert it inside perpendicularly. Do not try to angulate it medially or laterally, because you have already marked your incision in the middle of interlaminar window in this particular case. So try to insert the dilator perpendicularly inside. Do not try to poke it. You have inserted the dilator in AP view. Now you have to confirm the position of dilator into the lateral view. So in this particular case, you can see our dilator is resting at the inferior end plate, or it is parallel to the inferior plate. Why we are seeing dilator at the level of the inferior plate, and why not in the center of the disc? Because we have taken the center of interlaminar window as a landmark, and interlaminar window is little bit inferior caudal to the this thing, disc space. So if it would have been the entry at spinolaminar junction, our dilator would be either at the center of the disc space or little bit at the upper end plate. So now as we have confirmed the position of dilator in the lateral view, now you can insert the working sleeve over the dilator. The working sleeve should be inserted with the VVL facing medially. So again, confirm the position of working sleeve in lateral view, and now you can insert your scope and start doing endoscopic surgery. So the next video will be endoscopic view of the surgery. So now the next video is all about endoscopic surgery. So now here you can see we are inserting the endoscope inside. So the moment you insert the endoscope, you are going to see the soft tissues in the interlaminar window. So you can see here I am just burning the soft tissues in the interlaminar window. This is again very important. So do not try to just remove those soft tissue with the help of forceps before coagulating, because sometimes the muscle tissue in the interlaminar window, they bleed like hell. So try to avoid its manipulation before burning it. So I have coagulated, and now I'm removing the soft tissues from the interlaminar space here. Okay, so the structure, the yellow structure which you can see here is nothing but the yellow ligament, that is the ligamentum flavum here. So let me orient you first. So 9 o'clock here is cranial, 3 o'clock is caudal, 6 o'clock is lateral, and 12 o'clock is medial. So you can see we are removing the soft tissues from the interlaminar window here. So the next step is to identify the landmarks. So there are few bony landmarks like the superior lamina, base of the spinous process, then medial border of the inferior articular process, and then the inferior lamina. So these are the landmarks which you should identify in each and every case, whether it is a stenosis case or whether it is a case like this where you do not have to do bony decompression. But the identification of bony landmark is very, very important. So I can already see all the bony landmarks here, but I am just removing those soft tissues from the interlaminar space for you to identify the landmarks. So this is nothing but the fat which is lying in the interlaminar area and some soft tissues over the inferior articular process. So I am just burning to make the landmarks more clear. So So it is very important to identify all the bleeding points and coagulate them. Now here I am preparing the ligamentum flavum for the flavotomy. So I am just clearing tissues all around, identifying the landmarks. So the yellow structure which you can see here is nothing but the ligamentum flavum. So now the next step is phlebotomy. So as we have discussed already, we are going to start our phlebotomy as close to midline as possible. So here what I am doing, I'm just trying to remove the ligamentum flavum layer by layer with the help of annular cutter here. So I'm trying to cut the ligamentum flavum layer by layer from superficial to the deeper layer. So here the important part is that the tip of the annular cutter, which is one of the sharpest instrument, so the tip of the annular cutter should always be under vision. So rotate your camera as per your need, but all the time the tip of the annular cutter should be in the vision. So you can see here we are gradually going towards the deeper layer. So this was the deeper cut. Now you can see we have bridged the epidural space here. We are already in the epidural space. Now you can rotate your sharp instruments with the tip sharp tip towards lateral aspect, so that it will avoid any injury to the underlying structure. So now we are removing the ligamentum flavum from medial to the lateral. So we first cut was on the medial. We opened the epidural space medially. Then now we are shifting towards lateral recess. So this is the epidural space. You can see the epidural fat very clearly. Now we are changing our instrument. So this is the tube sheath punch. So the ligamentum flavum has been removed from medial to the lateral aspects. Now we will try to visualize the lateral recess. So here we are removing the ligamentum flavum from the lateral recess. At every step, whenever you see any bleeder, try to coagulate that bleeder. One more thing here, we are not touching the fat as of now. We already know that we have opened the epidural space. We can see there is a fat. We can remove this fat, and the neurological tissues will be just in front of this fat. But we are not removing this fat because this fat actually is protecting our structures underneath. So now I have removed the fat so as to visualize the structure and to understand the amount of the lateral recess decompression here. So I'm removing the fat, overlying fat, and then I'll visualize the traversing nerve root, then visualize the border of the dura, and then we'll decide how much lateral I have to go. So again, whenever you see some bleeders, try to catch those bleeders as early as possible. So now we are going to do dissection more laterally in the lateral recess. I'll remove the ligamentum flavum in the lateral recess. So the target here is to identify the lateral border of the traversing nerve root. So that will again become the parameter for the adequate decompression. So I am going to remove the flavum in the lateral recess with the help of tube sheath punch. So slowly the lateral border of the ligamentum fluum is become visible here. You can see. So this is the young patient with the very wide interlaminar window. So the reason that you can see here, there is a lot of epidural fat. So it's because of the wider interlaminar window. So the remaining space other than the neurological structure is occupied by the fat. You can see the fat is creeping from all around. So here I am removing ligamentum fluum in the lateral recess and some part of the middle border of the superior articular process here. The purpose here is to create this enough space laterally so that I can retract the nerve root medially with the help of the working sleeve. So this was a contained disc. So now you can see I can retract the nerve root medially. I think there is enough space laterally. We can dock our working sleeve in the lateral recess and then retract the nerve root. So before retracting the nerve root, try to see whether the root is mobile or not. So we have retracted this root medially. Now this is nothing but the disc. So the next step is discectomy here. So we have retracted the traversing nerve root with the help of tip of working sleeve medially. So now I am just ablating the vessels, epidural vessels over the disc. This is again very important step. If you start without ablating the vessels, so they will start bleeding. So it will certainly hamper your visualization. So now with the help of this annular cutter, I am just cutting the superficial layer of the annulus. So this is the contained disc. The fragment is subannular. Now you can see here the fragment is coming out of the annulus. So in all the cases of the disc prolapses, whether it is a contained disc prolapse or sequestrated disc prolapse, always try to debulk the fragment all around. So that to remove this fragment in one piece, it is very difficult to get such fragment in one piece, in at least in young patient with this subannular content fragments. But you should at least try for it. This is the sticky fragment. I don't think it will come in one piece. So this was the larger fragment which is coming out of the disc space. So here again we have retracted the traversing nerve root medially. So these are some free fragments which are coming out of the disc space. So again, achieving hemostasis is very important. Once the epidural vessels start bleeding, it becomes very difficult to control them. So it is always advisable, whenever you see it, coagulate them. So here what we are doing, we are now going inside. We will try to remove the free fragment from inside the disc space, and then we'll excise some part of the hardened annulus. So now you can clearly see this is the annular rent which we have created. So we'll just make it more bigger, so that we can remove the free fragments from inside the disc. And I feel there is some central hardened annulus. I'll try to remove that part as well. So here I am removing the hard annular part near the inferior end plate. So you can see here, this is the hardened annulus here. This is the annulus in the lateral recess. This is nothing but the central annulus. So what I am removing now is the central annulus. So I have retracted the nerve root till the midline. So it is only possible with the help of discoscope. You should not try this with the help of stenoscope, because stenoscope has a larger diameter. You cannot retract your nerve root till the beyond the midline. This is one more fragment, which is soft fragment, which is coming from the midline. We'll try to flatten the annulus. This is all annulus from the midline. So if you do so, you have to remove the pressure on the nerve root frequently. So once I take a few bites, I'll just release the pressure and then again retract it medially. These are all free fragments which are coming from the disc space. You can see here, this was again a big fragment which came out. This is the part of hardened annulus superiorly near the superior end plate. So we have removed the annulus from the inferior end plate. We have removed the annulus from the superior end plate. We have removed from midline as well. Sometimes this happens when a huge bleeder opens up and it hampers your vision. So there are few techniques to identify the bleeder. So what I'm doing right now, I'm just focusing my camera as close to bleeder as possible. So take your lens of the camera closer to the bleeder and then you can identify it. We have stopped the bleeding. So we have completed our annular work. We have done annuloplasty. We flattened the annulus here. Now I am going inside the disc to remove the soft disc fragment, free disc fragment which are lying inside the disc. So in young patient, the fragments they keeps coming from the disc space. So you have to stop somewhere. So what I would suggest, once you stop getting bigger fragments, stop going inside and stop removing the smaller fragments. So these are some big fragments which are coming inside from the disc. So once they stop coming, once the bigger fragments they stop coming, I think we should stop. Some surgeon use curate to scrape the loose fragments from the disc, but I don't think it is necessary. So I just go inside with the help of forceps and try to remove as much as fragment as possible. We do not want to remove excessive amount of the nucleus pulposus from the disc, otherwise patient will start having a disc collapse and will develop the back pain in future. So once these larger fragments stop coming from the disc space, I'll stop. But yes, in young patient you have to spend more time in removing these disc fragments from the disc space. They keep on coming. So in the end, what I do, I just put my radio frequency ablator, tip of the radio frequency ablator inside, and just burn all the or shrink all the free fragments which are the potential cause of the recurrent disc prolapse. So I'll just put the tip of radio frequency ablator inside the disc and remove, burn as much as disc fragment as possible, and then I come out. So now we have completed our discectomy work here. So this is nothing but the final decompression. You can see this is the traversing nerve root and the dura. So this is nothing but the traversing nerve root. We can retract this traversing nerve root very easily without any tension. This is nothing but the axilla. So here there is some hardened annulus which was lying there. So I'm just removing that annulus. So this is sort of a step of final survey where you have to see all the things, whether you have removed the disc, whether you have removed the annular hump, whether the root is decompressed completely or not. So these are some steps which you have to follow once you complete your discectomy. So again, in this particular case we haven't done any bony decompression. The reason being wider interlaminar window. So we just removed some part of the ligamentum flavum. So I can easily retract the traversing nerve root medially with the dissector. So there is no underlying disc fragment. So this is midline. So this is some remaining part of the annulus. So now you can see the overview here. The root is completely decompressed. So you can see this is nothing but the flavum window which we have created. It is not more than 6 to 8 millimeter of window which we have created for the entire surgery. So this was the flavum incision we used. So it is not more than around 6 to 8 millimeter of the flavum which we have removed to get access to the epidural space. So here is the beauty of endoscopic spine surgery. You can see here, once we remove the working sleeve here, all the tissues like muscles and fascia, they just fall back to their normal position. And this is end of the surgery here. Now let's see the post-operative MRI of this particular patient. So this is the post-operative MRI. You can see we have removed the entire disc fragment. At the same time, we have removed the hard annular hump as well.